Brian, prone lying extensions are a staple of the McKenzie program. It brings about tremendous passive extension. Can you talk for a minute how we add a snag to this technique, which we feel may in fact make it a little bit better?
Yep. Yes, and the proof of the pudding is in the eating. You have a patient who tries an extension and lying a la McKenzie because it's indicated, that the assessment tells you that you want the patient to do extensions and lying because they have a discal problem. Now, every time Mr. Ed pushes up, that's the extension and lying, but he's still compressing facets, and that perhaps may be of no consequence, but just as an insurance, yes, in the land of litigation, I am going to get hold of his spinous processes, and if it's a 4-5, I am going to apply a cranial translation of the facets at that level as he comes into extension, so there's no jamming, and the patients, in my experience, say, hey, it's easy to come up. They're trying to get back, they're trying to do something that's useful for the disc, and if I do that, they seem to come up further, and I can give them some overpressure. Can I just demonstrate it? My left hand is underneath the patient. Can I get underneath you, Mr. Ed, all the way around? And I hope you can see my fingers the other side. Here I am locating, say, on the spinous process of L4. There is my separation of those facets. While I'm separating, you will come up, Mr. Ed, all the way, and when he goes as far as he can, I give him a little bit of help and down. And it also creates a fulcrum at 4-5. It's localizing the extensions and lying to that segment by having my hand there.
So you're making sure that as you bring him up, as he presses up into extension, you're giving him some assistance.
A little bit, yeah.
And your glide is cephalad.
Yep.
So your elbow stays behind your line of drive again, gliding this way. There's not much of a posterior to anterior vector.
You would make them worse. Yep, yep. But I think when you push up, I'm just going to ask him as if he were a patient, just push up for a moment. Now down. Now push up again while I'm... Do you feel that locates it to that segment?
Oh, yes.
Oh, yeah. So I just think it makes that procedure better. And following that, and that's where I might differ from the McKenzie people, I ask the patient to come up on their hands and knees. Can you come up on your hands and knees, please? Goody. Now, can you separate your knees so they're wider than your hips, which is important? And now, with his hands stationary, I ask him to take his hips towards his feet. Now, when he's doing that, this is to sort of give a little stretch to the facet joints. And as he does it, he can hollow his back, he can hump his back, he can do what feels best for him. And quite often, the further up the knees are, the more they feel the stretch in that part of the spine. No pain whatsoever with it. And just come up again, and then down again. And that would be something a patient did. Now, what would I do? Let's forget the discal theory now. Let's say it's an upper lumbar facet problem because it hurts when they go back, and you've localized it to a certain level, say to L3-4 on the left. This works brilliantly. I'm going to locate on the appropriate transverse process. I'll use this sponge. I am now going to wrap round his tummy for fixation, and when he goes back, can you go back towards your... I'm stopping you. Can you feel I'm stopping you?
Yes.
And let go. Now, this is doing something that's never been done before. We're getting a distraction of that segment from below up. It's the lower part that is moving away from the upper part. Normally, it's the upper part moving away from the lower part.
So how important is it for you in your... You've been practicing for 2-3 years now?
Yeah. Oh, thank you. Yeah.
How important is it for you to visualize what you do?
Oh,
do you still, when you treat a spine, do you still see
vertebrae.
The L2-3 segment? Do you see the facet joint on the left? Do you see the segments being opened and closing? And by visualizing things, do you think that has helped you become a better manual therapist?
Without question. Most people are totally confused. They're not quite sure what's under there. So that's all I see. When I'm there and I can feel that bone. I can see where I'm located. And as they're going back, I can visualize what's happening at that segment.
And isn't that exciting? 20,
It is.
30, 40 odd years later, when you still visualize what it is you're trying to accomplish, you feel something under your fingers and you're imparting a change in the tissue tension, the joint spacing, and the patient has symptomatic changes, improvements. It really confirms the theory that you're practicing under.
And the outcomes I'm getting.
Right.
Let's assume, can you just quickly, just lie on your tummy and then come back to that position. Part of my assessment is to do a spring test on different levels. I spring on L23. Oh, he says, ouch. Okay, I know where it is. Up he comes on your hands and knees. I'm now going to locate on the transverse process at that level. When I've done, say, half a dozen of these, I lay him down and I do a spring test. And he says, that's better. I say, of course. But you must try this. If you've got someone with upper lumbar, in particular, pain in this area, it's elicited when you do a spring test. Get them on all fours, locate on the appropriate spinous process, and back you go. Oh, knees wide apart, he's done that. Oh, good boy. Back you come. Goody, goody, goody. Now, just another little point. If you bring your knees up further and go back, you might feel it's more effective. Just go back. Do you feel that?
Put more arch in the back.
Yes, yes, more. Because he's come more proximally with his knees, he's getting a stretch just by sinking down now.
So if he has pain on the left and you want to impart more of a stretch, you might bring the left leg forward as he sits back.
That would be a follow-up course, but yes. You're giving away secrets. But anyway, that's exactly right, bless you. He's not silly. Come on, back you come. Oh, I love this technique. Thank you.
Okay. Now, you've talked several times about the mid and upper lumbar spine.
Yep.
How would your hand contacts change? How would you visualize different things changing if you had to deal with the lumbosacral segment, the L5-S1 segment?
Yes. Can I please show that, because I think it's important.
Please.
It's going to be hard to film, but I would, if a spring test told me that they have a problem at L5-S1, they haven't got a blown disc, they haven't got pain down the leg, but every time they go back, they've got back pain at L5-S1. They go back to, oh, that's sore. I will locate on the articular pillar on the affected side, and I will go straight up cranially, you call it cephalically. Yep, same meaning. And while I'm holding that, they come back if they're on their hands and knees. Now, can you come up on your hands and knees just for a moment again? Feet over the end. Yep, yeah, well over the end. Yep.
Brian, I'm sure in the other segments you've gone over thumb contacts.
Yes.
Can you talk for a second just about your thumb contact and the reinforced thumb contact?
Yep. As he comes back, there's quite a force on my thumb because I'm trying to keep him from moving. And just to use one thumb and sustain that pressure while he's coming back, it's almost impossible. So one thumb goes on the other to reinforce it, and back he comes. And a bit of sponge is even better. So there we are. I'm locating, and back he comes. Can you feel that? Mm-hmm. Yep, and up again.
And again, your line of drive, okay, is this way. So your thumbs are not pushing down.
No.
They're almost pushing up. They're almost rolling up to some degree.
And if you look at the skeleton, the articular, look at that articular pillar. There's almost a place for your thumbs. I think you were meant to do it. This back was designed so that we could treat them if they had a problem at LS. And you can do the other. Which side do you get your leg signs? Well, that's the side I'm going to stick to anyway. Now, if I'm doing that and he's got an L4-5 problem, I'm going to make him worse, because as I've fixated L5, as he's coming back, he's jamming 4-5.
Right.
And the result is he doesn't feel better.
So in that instance, you would move to the level above.
Yes, yes, yes. And then you use the lateral border of your hand. But that's a very useful treatment at that level. We'd now like to show you a technique using a belt, which is very effective in distracting facets at a particular level. Now, we place the belt around the chosen spinous process, as we did when the patient was standing and using a belt, but they're on all fours. And the other end of the belt is held by the patient. Now, can you put your hand to the end, really secure it, and get them as far away from you as you can. Now, an American company, OPTP, makes a belt that's got some anti-skid material on it, and this belt's a little bit short, but I'll just go through the procedure. You locate on the vertebral segment that you need to distract, on the vertebrae above, and it's like the lion exercise. The patient takes their butt away. Now, he can't go far, because that belt stops him, but he is now distracting the segment below where the belt is situated.
And that's a key thing that you brought up, Brian. This is similar to the lion exercise.
Yes.
But the amount of motion is severely restricted because you're trying to get separation at one level.
That's right.
So there shouldn't be
Not much at all.
8 inches of translation. It's just a very small amount.
That's right. And instead of using my hand, which I found effective, this is the patient's using a belt, getting the same result. The only difference is it's a central technique. But we've now come up with a way, and once we show it, that's the way the viewer will always apply the belt. Now, we're going to take this belt, thank you, and it's not long enough, so we will you can use a piece of rope, you can use anything you like, just to make this loop bigger. And if I put it this way, now when you start going back, there's fixation there. Wait, now let's talk about it. Let's assume he's got a problem at L3-4. The belt is located on L3, the sponge process of L3, but because the belt lies obliquely to the corner of a bed, when Mr. Ed comes back, there's a greater distraction on the side, on my side. In other words, that gives a greater distraction on the left side of his spine. So he's now distracting a facet just where we want it. And he again can vary his flexion of his knees and hips to find out which feels more effective. Can you bring your knees up a bit further? And back again, can you feel that's more effective? Oh, look at straight away he feels it. And you'll comment, you could bring that leg up a bit further. That was brilliant. And again, yep, and now you're stretching. So if a person has pain emanating from L3-4 and it's on one side, you put the belt obliquely. Most people sleep in a double bed, and if you wanted a bilateral technique using this procedure, Mr. Ed would be on the bed in this direction. So when he goes back, it's a bilateral technique. Now, just a word of comment. On my courses in America, I always ask people if they've ever had groin pain. And every time I ask, out come patients. And I had a guy in my room some years ago who had had groin pain for over a year. And it was so serious that they even operated on him to see if he had some internal problem in his abdomen. And then the doctor, by chance, said, go and talk to Mulligan. And he comes to see me. And I remember saying, look, you've got groin pain. I don't know whether I can help you. I'm going to test your spine. And can you just remember the letter L and the number 2? So I said L2. He said, L2? I said, yes. And I lay him on his tummy and I did a spring test. And I said L5, L4, L3, L2. When I got to L2, he says, ouch. I thought, I wonder if we can fix his groin pain. And this is what we did. And I saw him 3 times, but it had gone after a year. He was able to eliminate that groin pain, and it must have been a jamming of that segment on that side that was producing his groin pain.
And you know, Brian, you bring up a very good point. So many people throughout many of the courses ask, how do you know where to start?
Knowledge.
How do you know where to begin your treatment so that you're not wasting your time at the L5, S1, and it's all through knowledge of the anatomy and where joints move in the range of motion, and also nerve distribution, referral of pain. And Cyriax did such a great job at outlining and differentiating pain, referral patterns, selective tissue tension, and referral patterns. And that is another way to streamline your treatment to be as effective as you can.
No, it's nothing. And, you know, almost now belts are normally about just over 2 meters or 6 feet long. It might help if they made belts another 2 or 3 feet longer so that you can just hook them on the corner of your bed. But it's no problem tying a bit of rope or anything to the belt so that it makes it longer. And the longer the better, because you've got a translation in the treatment plane. If you had it fixated here and he's going back, that's useless. It does nothing. Absolutely nothing. That is a lovely treatment. You can even use it centrally if you get in bed at night, you get restless legs. You just get up, shove a belt on about L1, and just do a few of these, and I guarantee your restless legs feel heaps better. Or you can do a self-snag about L1 and say, hey, my restless legs are better.
Okay.
The work's being done by a wonderful therapist in America on that particular topic, and it'll be published in a year or so. Goody.
Look forward to it.